Hi, good evening, everyone. My name is Annie Benzie. I am the chair of the Phillips Subcommittee for the SSAT Complex GI Surgery Fellowship. Welcome, everyone, tonight for what is sure to be a fantastic talk on a very interesting topic. We are honored to have Dr. Daniel Jones here this evening as our moderator. He's a professor and Benjamin F. Rush Jr. Chair of Surgery and Assistant Dean of Simulation Innovation and Scholarship at Rutgers, New Jersey Medical School, right up the road from me. And welcome. Thank you so much for accepting this invitation, Dr. Jones. And if you wouldn't mind, just give us your, as Dr. Jacob said, pearls of wisdom on tonight's topic.
Yeah, that's a tough request, but Annie, I said to keep it lively and interactive, so I think I can do that for sure, as long as Dr. Jacobs allows me. We're really pleased to have Elizabeth Jacob here as our lecturer. She's a graduate of Dartmouth, got her MD from BCU, did a residency at Dartmouth and Bassett, and now doing her fellowship in MIS at Valley Health Systems here in New Jersey. So without any more to do, let me turn it over to Dr. Jacob to talk about surgical teleproctoring.
Good evening, everybody. Thank you so much for joining us today. I will be talking a bit about surgical telementoring. And it's going to be interactive. It's very friendly interactive. So don't be offended if I just start asking you guys questions as we go along. I don't have any disclosures, and I'm not going to be discussing any unlabeled uses of a product tonight. So what is surgical telementoring? Well, it was introduced in the 1960s primarily, and it's the idea of exchange of information by providing remote guidance, specifically to an inexperienced surgeon from an expert surgeon. Now, the term telemedicine is a global term for exchange of medical information from one location to another by some telecommunication system. The elements of a telementoring system would include a secure network, ideally HIPAA compliant and high encryption. And then you have two parties. One is working from a mentor's office, one who can see what's going on in the operating room, has a microphone to talk to those in the operating room, as well as a loudspeaker so they can be able to hear what folks in the operating room are saying, as well, ideally, as a telestration system, which is, think of it as like a whiteboard or a way to draw and explain what moves the mentee should make during the operation. And over into the operating room, you should have a monitor where you can actually see your mentor, as well as a camera providing two views. One of your hands as an operator, what you're doing in terms of the endoscope and what buttons are you pressing in order, or how are you holding the scope in order to get a specific view, or how you're holding your instrument so you can have a specific laparoscopic view, and the endoscopic or laparoscopic view of what's going on in the operating room. You also want to be able to communicate to your mentor by microphone and have a loudspeaker so you can hear what they're saying. Some scenarios in which such a system might be helpful are providing basic training for learning surgical skills. So think of a resident learning in a simulation lab from a mentor who could be across the country, or learning a new surgical method. So this might be a surgeon who's already in practice, and suddenly there's a robotic platform, but they haven't done as many robotic cases. Now, one could have a mentor in a different down the street, or even in another state, provide feedback onto that surgeon as they're performing their first robotic surgeries, as an example. And then lastly, one might be performing a new technique, for instance, like one anastomosis gastric bypass, and that expert surgeon could be viewed by another group or party live from a panel of expert surgeons providing commentary as that surgeon is performing that case, as well as sending that information to a group or party who can learn that technique for the first time if they've never seen it. Some of the benefits of such a system would be avoiding the cost of traditional on-site mentoring, including transporting a mentor or a mentee to either location. It's potentially less time-consuming, and one can avoid transmissible diseases like COVID. mentees might be located as well in places of political or civil unrest, and it might just be difficult to transport or even unsafe to transport a mentor to that location. And ideally, rather than just a single preceptorship where one goes to a different state, learns the technique, and comes back and tries to start from there, you can actually have ongoing case observations and opportunities for feedback as you perform those specific procedures. I guess before I go on to this, has anyone in the audience been involved with telementoring or teleproctoring? If you could just say yes real quick.
Yes.
Yes.
Okay, great. I'm going to call on you later. All right, some cases of international teleproctoring. This goes back into the 90s, where urologists at Johns Hopkins actually provided guidance to 3 surgeries in real time, 1 in Austria, Innsbruck, Austria, as well as 2 in Bangkok, Thailand. This, again, was in the 90s, where there was definitely a latency in terms of the technology that was allowed, such that you had a second transmission time delay. And so that was one of the limitations of such technology at that time. Just a year later, one battleship group, the USS Abraham, was able to provide intercontinental telementoring with surgeons from the coast. So 5 laparoscopic inguinal hernias were able to be completed on the Lincoln under guidance from land-based surgeons thousands of miles away. And if you think about the cost as well as the safety to the battle crew and the patients of transporting those specific patients to those land-based surgeons, it made a lot of sense for that group to have just on board guidance by surgeons thousands of miles away. Even still back in the 90s, a lap chole was even performed in an Ecuadorian rainforest under the guidance of surgeons in New Haven, Connecticut. And if you have a sense of how latent or how delayed this speed, it's actually kind of very impressive that they were able to perform that surgery with only 12 kilobytes per second. But is telementoring as good as on-site monitoring? So this was a study performed at VCU, and 20 Romanian medical students were trained using a virtual surgical simulator called LabSim. And they were divided into having a on-site mentor in Romania versus having a telementor from Richmond. And essentially the gist of the paper is that they were able to both gain surgical skills that were statistically significant, and neither the on-site mentor nor the remote mentor provided any better per se guidance, which means that they suggested that there was equivalent learning capabilities. And this is just a systematic review of tech capabilities reported by telementoring systems. And again, no noted worsened outcomes were seen in these studies. So this goes into more recent instances of telementoring. Has anyone used Google Glass before? You can, again, just sort of shout out yes or no.
No.
Yes? Okay. So Google Glass, definitely very much the rage back in the 2010s. And an Ohio State University orthopedic surgeon performed arthroscopy with Google Glass, transmitting the video to a colleague, as well as live video to university medical students in real time. More practically, it was actually used to train Paraguayan and Brazilian surgeons, and in order to allow ongoing remote evaluation and support to those surgeons who are learning a Liechtenstein inguinal hernia repair technique. Again, kind of touching on how it allowed a platform so that the surgeons didn't just have a one and done mentorship experience, say remotely or far away, but they could actually have ongoing feedback about how to improve their techniques in their local countries. This was actually with the Zoom platform, which all of you are familiar with because we are all sharing this talk via Zoom. But an expert US GI surgeon taught and guided a Ugandan surgeon live, while that Ugandan surgeon, who hadn't had any significant experience with endoscopies, how to perform endoscopies. And they actually had 95 guided endoscopies just with the Zoom platform. And as you can see here, they mounted 2 separate cameras. One was actually showing the endoscopic view, which unfortunately is not shown in this photo, but the second camera had it on the surgeon's hands. So the proctor could actually provide guidance as to how to turn the scope or which buttons or dials to press next. This, I admit, is kind of an older platform compared to Google Glass, but the Visit Aura 1 from Karl Storz was cutting edge because it connected the remote surgeon's laptop to a mentoring surgeon with, as you can see here, a video of the actual operating room, as well as an endoscopic view to the remote and to the OR surgeons as well. It allowed the remote surgeon to control this externally viewed camera and had telestration and laser pointing capabilities, and it was HIPAA compliant with high military grade encryption. The Remote Present Virtual Independent Telemedicine Assist, RPVITA for short, was one step above the Storz machine. This robot allowed the mentor to roam, see, hear, and interact essentially with the environment using a joystick. It was also equipped with infrared sensors so that it didn't bump into any needed and important equipment in the operating room and avoided collisions. However, it did cost $4,000 to $6,000 per month, at least in 2013. This is an example of potential military investment, similar to what I described with the battleship model, but in the field. It's called the Star Alliance system. And essentially, this is a concept video, as it hasn't been
injuries require
quite rolled out to the public or to our actual battlefronts. But the idea is that you would have a medic on scene who would be able to be provided guidance on actual procedures in real time. So as I scroll through this video, you'll see that our medic wears a HoloLens, and our land-based surgeon, or remote surgeon essentially, has 2 views of what's going on as they get the consult. They have the view of what our medic is seeing, as well as a even further zoomed out view transmitted by a drone, which I think they'll show shortly. So yeah, this is the drone's view of what they're seeing as the medic is providing assistance. And this STAR system would allow for a telestration where they can overlay images over to what the medic is seeing in order to provide guidance as to where to put the incision for the crike that's needed at this period of time. Just as a framework for how to even develop a surgical telementoring system if one wanted to incorporate that into one's educational program. SAGES has come up with their Project 6, which comes with the idea of I've got your back from the military. And so the goals of the Project 6 Summit was to summarize the existing evidence for surgical telementoring and detail conceptual frameworks that could be used, as well as provide a structured framework for what a curriculum could potentially be built upon in the future. So how can we now use telementoring? While it doesn't provide as great real-time feedback into one's inoperative moves, you could easily record your cases with things like OR Hub or Intuitive Hub and share that game tape with a mentor, or use it as a teaching tool for one's mentees, as how I do this procedure, and get feedback from both your mentor as well as your mentees. This is a screenshot of the My Intuitive app, and Intuitive now offers a collaborate virtually function, which would allow operative physicians to use Intuitive Hub, which is a platform put out by Intuitive, to provide real-time intraoperative guidance. So it's similar to some of the other systems we've already seen, where one would have an intraoperative view as well as a not only of the endoscopic or laparoscopic view, but also to the surgeon themselves, as well as the mentor. And the mentor would also be able to pull this up on their iPad or laptop and provide telestration as to their advice as that surgeon is operating. Even now, surgical telementorings, where an expert surgeon is is performing a new procedure for the first time, and a group or panel of expert surgeons provide feedback to that surgeon, is happening even today. This is a remote conference back in September where one surgeon was providing that same idea of one anastomosis gastric bypass, and he was giving his live feedback as to how he does a procedure, and a group of experts were providing feedback to him as to what essentially kind of an ongoing commentary as he was doing that procedure, and they were fielding live questions from the audience as he was performing that procedure. Surgical mentoring isn't perfect. There's definitely still the gaps in latency, so more austere environments may still have limitations in how quick their internet speed can be, and so there might be lag between the video and audio. And that goes into the tech being still just more limited at remote hospitals. One should definitely factor in having secure and HIPAA compliant transmissions so that they're not overridden, so that there's any breach in patient information. And the idea of liability between the on-site surgeon and mentors still remains to be solidified. And like I referred to or alluded to with the RP Vita system, it can be quite costly. My last question is, has anyone used HoloLens? See, Dr.
Yes.
Gerard.
Yeah,
Perfect.
so we use it actually to teach anatomy, which is really cool. So our medical students actually use HoloLens technology. And Dan, we have a project right now actually looking at consent for Whipple using HoloLens technology compared to standard consent, which I think is really cool.
Tell us a little bit about that, Rohan.
Yeah, I was going to say.
Yeah, if that's okay, Dr. Jacob, sorry to jump in. So
No, this is welcome.
our med school is a little bit kind of forward thinking with regard to anatomy, and also honestly resources are difficult because getting an anatomy lab is one of the most expensive pieces of UME education, as Dr. Jones can probably tell you from running a medical school. So we've been creative with this and using HoloLens to teach, for example, the cardiac module, and it's pretty amazing. You can go inside the body and see what the thoracic duct is, for example. What we've done subsequently, and this was actually the project of one of my MS1s, was to come up with a program where we actually have the framework of what happens with a Whipple in 3D. They wear a helmet, the patient, and they actually walks through the concept of what a Whipple procedure is with regard to surrounding structures and what you do. We've got a project looking at how well they seem to understand that operation with HoloLens compared to standard. Dr. Benzie can see my artistic capabilities on the back of the table where we have sustainable coverings for the table that we use as artwork platform. We're looking at that right now. We don't have enough. We have about 10 patients in each arm right now, and we're actually analyzing the data right now. But this is, I think, a really interesting use of technology, Dr. Jacob, to actually help on the patient side.
Yes, most definitely. No, that's a fantastic use of technology to train the next generation so that they would have a better idea and sense of specifically what the anatomy looks like in a textbook by wearing HoloLens, because providing that 3D view, it isn't always translated as readily when just reading a textbook. This is kind of nearing the end of my presentation. I was just going to point out at Mount Sinai, they have actually co-established a hospital in Uganda, and that's kind of what I alluded to with the Ugandan surgeon who learned a lot of gastroenterology in coordination with Mount Sinai. They actually provided a HoloLens to that Ugandan hospital, and that Ugandan hospital has excellent internet because it's co-established with Mount Sinai, and it allows remote surgeons to provide intraoperative guidance and annotation by overlaying holograms to the operative field. And the hope is that it would optimize the Ugandan surgeon's surgical technique and outcomes. I just want to briefly share with you a video of what that looks like for that hospital at that time.
The problem is enormous. Right now, on a worldwide basis, over 5 billion people do not have access to simple surgical operations. If we look at the magnitude of the problem, 17 million people would be expected to die from problems that could be corrected with a surgical intervention. The Tribirwa Surgical Center in eastern Uganda is a sustainable program that we can provide affordable, safe surgery to everyone. Our program has always been around looking for ways to create not only surgical care in a region, but a sustainable program of surgical care. It is unlikely to be solved by exporting or importing surgeons into regions of need, but finding more efficient ways to use technology to share surgical knowledge. Microsoft Teams and Microsoft 365 have been game changers.
We've been able to start practicing telesurgery, where I can invite the assistance of an expert from any part of the world.
The Dynamics 365 with Remote Assist, coupled with the HoloLens technology, allows us to have surgeons operating with Uganda completely connected with surgeons here in Mount Sinai.
Through this HoloLens, Dr. Marin is able to see exactly what I am seeing. He's able to have a real-time view of my surgical field 7,000 miles away.
This young girl comes in with a significant problem that isn't commonly encountered in this community is something we see here at Mount Sinai multiple times on a weekly basis. What was your plan in terms of incisions?
So my initial plan was to make an elliptical incision.
Sometimes it's actually helpful to do a circular incision. I'm just going to trace out for you what I'm thinking.
It was so clear now. How I would have approached it would not have offered me the advantage.
So the ability to evolve in the technology and share our knowledge with our Ugandan partners allows the Ugandan team to evolve as well. Their nurses, their anesthesiologists, their surgeons all get confident, get capable of doing things. If we think about it in the simplest form, consultative surgical support can begin with a telephone, a simple.
All right. So yeah, I think one amazing aspect of surgical telementoring is to provide our surgical resources to austere environments and just places that don't have routine access to surgeons, or just when you need help and you're located in a austere remote location, just being able to have the technology to reach out to a friend, a mentor, a colleague is very powerful and hopefully a great way to a bright new future. I appreciate your attention. I'll welcome any comments or questions you have about this presentation.
Well, let me start you with a few. I mean, oftentimes when we think about surgical telementoring, we're talking about the surgeon being somewhere else and the case occurring. Now, there's a lot of discussion about concurrent surgery where the surgeon's in two rooms. How is that any different than the surgeon being 200 feet away or a mile away or a continent away?
Yeah, especially when I haven't been in a hospital system like this, but I'm told that some ORs are being built with their robots and operating room. The console is in a completely separate room, right adjacent to the operating room where the surgery is being conducted, but the surgeon isn't in the same room as the surgery that's taking place. And it goes to your point, does the surgeon have to be, right in the same, does your co-surgeon necessarily have to be right in the same room as the surgeon that's on surgery that's unfolding? And I think when you have platforms like this, it really does open up your concept that maybe they don't have to be, your co-surgeon doesn't have to be right next to the patient at the moment's notice, potentially.
So back in 1993, Dr. Soper I was in his lab, and David's there. He's the chairman at Banner. And what we did was we put together a 50-foot cable to a computer motion robot. And so he proctored me doing a lap Nissen as the resident. from 50 feet away. I had probably his full attention. I don't know. Does anyone have a problem when this is 50 miles away or more? I mean, does a surgeon have to be in the room for the moral aspect of or if you just tell the patient what's going on, it's okay? And then how does that differ from concurrent surgery? Rohan, you want to tackle that one?
Yeah, so this is a real challenge, especially on the educational front, right? Because I think that, the way I sort of think about this is that there are components of a case that I think we need to have our residents gain familiarity, or trainees, I should say, gain familiarity with and be independent at as we teach them other nuances of that case. So, just to give you an example, and this is kind of, I had a case where somebody got into trouble doing a Coco maneuver and I was standing literally 10 feet away. But that could have been really, really problematic if I was even outside the room. So I guess one has to have EQ with regard to the extent of the catastrophes that can happen, which can always be the case, and also the your comfort zone in being able to get people out of trouble. I do, Dan, when we were both on faculty at ET Southwestern, there was sort of the standing joke that you were in your office, watching a TV screen that was, from the OR, and you knew where to say zoom in and say stop.
There was, and I did. You're correct.
and and you could say stop, wait for me, and I'll walk over the 300.
Yep, it was fun.
And but I think times have changed, and I think, honestly, to be frank, I think that's a good thing, because I do think, Dr. Jacob, you bring up a couple of issues, right? How do you approach, I mean, if you don't mind me asking Dr. Jacobs or any of the group, how do you approach consent? Because the patient also needs to know in a very transparent way how this goes. And just for those on the group, I mean, how did I approach consent for my first robotic Whipple? I mean, that was really, really ethically challenging for me, right? And I was totally transparent with the patient. It was a nurse who said, go to it, But what do you think about consent, Dr. Jones and Dr. Jacob?
I think you definitely have to just be completely open and honest to the moral obligation. I mean, if this were you, or this was your significant other, your family member, would you want your surgeon not disclosing that it's their first robotic surgery, or not disclosing that they're not going to be at the bedside 100% of the time? I think it's, it's important to disclose those things. And if the patient has a problem with it, then you don't necessarily operate that way. But to your point, there may be those, like that nurse that you had mentioned, that are okay with that approach as well.
So Dr. Jarraj is right. I trialed this out of Parkland, and then I moved to Boston in 2003. I had this great setup where 200 feet away, I was hooked into the OR. We had external cameras and internal cameras in our endo suites, and a microphone that I could talk back and forth. And what was the coolest is I could John Madden on the screen, and I could actually telescrate on what was being seen. And that was 2003. But when I went to the IRB and I wanted to study resident autonomy operating with the use of teleproctoring, the IRB shut me down. And they didn't object to me doing it, but they somehow objected to me studying it. And so I couldn't get that past the IRB. I tried several times.
And if you wanted to be involved in a program like the one you're talking about, Dr. Jones, I mean, the other thing is to go to the literature and point out how operating remotely and being, 200 feet away or whatever have you, it doesn't worsen specific surgical outcomes as well.
Well, I don't think in 2003 there was that literature you're referring to that was going to be robust. There was a lab chole done in the United States and done in Europe, and that was about it, I think, at the time.
Right.
Other comments? David said he had to run to another meeting, but wanted to talk about AI.
I do, and I think it's your topic is fantastic. I really enjoy, very good presentation. And I just want to mention something that I think it adds to it, which is the analysis by AI. And we've been doing that experience. We've been having that experience over the past year where we're uploading everything that we do in terms of some of our bariatric procedures. We're uploading to the cloud, analyzing that with AI, and then not just giving feedback to the fellow and medical and residents, but also for us. It's a tremendous help. And, this is under IRB, and hopefully soon you guys will see some of those results.
Well, the screenwriters had a big strike because AI was writing the scripts. If you teach this AI how to do robotic thinking, you may find that you'll also be on the striking.
I think one of the, maybe, but I think one of the things is how AI learn and about our maneuvers and how we can improve teaching AI on what we do. And it's very interesting, and I think it's a fascinating issue.
So, David, we're actually been doing the same thing in our group. We can put an Oculus on 4 different people in the OR, give them a complex problem and see how they solve it, with the idea that we can then teach the robot how our group thinks. And again, we're in the infancy of doing this, but we're actually working along those lines as well. But I'm older than you, so I'm not worried about being put out of business.
No, not at all. Thank you. I'm sorry I have to step out.
Now, another thing that comes to mind that no one's really talked about is how we could use telementoring to replace morning rounds, or more importantly, weekend rounds. Wellness is important. And wouldn't it be great if the robot makes rounds for us in the morning and we can all stay home and maybe just connect from our laptop, as opposed to a cross-covering doctor who doesn't know the patient coming in and saying hi and goodbye. And maybe it'd be more efficient if we could do tele-rounds on the weekend. Well, before COVID started, I tried that study by IRB, and they also rejected it at Harvard, saying that they wanted the surgeon at the bedside. Of course, I should have tried again after COVID, because by then we were teleconferencing and doing anything anyway. So that problem seemed to go away. But today our problem with teleconsults, not from any distance, is if we're in a different state. So, Dr. Hassan, how do we deal with the limitations of the state licensing boards and our ability to telecommunicate?
Yeah, Dan, thanks again. And I was going to make a comment. Some of the points that you bring up are mainly compliance issues. Like for concurrent surgeries, that's usually the Medicare CMS has issues with the surgeon being doing 2 surgeries at the same time. So I think it's a layered argument. So if first that has to be undone, that they don't get that they allow for that.
But you don't think the public agrees with those decisions?
Well, I think it's how the perception, how you brand it. I mean, a lot of it's when it gets publicized that
Well,
the
it gets
surgeon
branded very differently when you have a lawsuit. So say you have a complication, I know how they're going to brand it.
But if I agree, so that's what it is. But most of it being in a different place and 2 surgeries happening at the same time, I agree that is not correct. But if one room is closing and you go into the next room to start the next case or bounce back and forth, that does make it more efficient, which again, how you define the critical part of the procedure is also debatable. But I think a big part of it is the compliance and the legal ramifications. I think one part is that same thing for that you talked about, the rounding, the tele-rounding. The point is that you can't bill for it if you're not there in person. Now, if that was relaxed, then your IRB would let you through. Same thing for your RB. I suspect the reason why the IRB in Boston didn't let you do it because they're worried about the liability. If they record something and something went wrong, would that be
Let's back up. I'm
admissible?
confused. What do you mean I can't bill for it? I can do a teleconsult bill, and I can bill for my morning rounds if it's a new patient.
I don't know if you can do those inpatients. We did teleconsults during COVID for out E&M codes, but I don't think that what the CMS or the insurance companies allowed that for inpatient consults.
So Daniel,
Well, this is a recorded thing, so I'm not going to say anything.
Okay.
The concern is supervision of residents. That's the difference. If you were doing the consult yourself, you can do it remotely. But if you're supervising residents, it's not billable unless on site. But we can take this offline.
Sure. No. So my point is, I think there's several layers to the problem. Like some of it is just compliance and legal issues. If those are sorted out, which are going to be challenging, I think there's a lot of valid use to this that will decrease the burden of delivery of healthcare and make it more efficient. So I don't have a solution. This is more of an editorial comment that it's complicated, and part of it is because of the compliance issues.
15 years ago, I went to Stryker and Butch Rosser and a whole bunch of folks, and we had a lot of meetings. But what I wanted to do with these endo suites and these new rooms was kind of what my intuitive has, where you could just link into an expert as a surgeon and get feedback. So you could have an immediate consult on a difficult gallbladder critical view, and you could light up a switchboard, and whoever was available could press the button and talk to you and get paid for teaching me the critical view or whatever I needed to do at that time. That crosses state boundaries potentially. There's all the question is whether the learner is going to learn what you want. Can you really get paid? Could you do it by CME credits in some other creative way? But I think that's where we're heading. I think if we think about it, as our technology evolves, we should be able to not just pick up the phone, but press a button. And I should have Dr. Ross in there giving me advice on how to stay out of trouble. Dr. Ross, can would that work? She's quiet.
She may be out gardening or shooting or on her motorcycle.
Dr. Welsh, what do you think?
While people are unmuting, Rohan, what do you think from an education standpoint? We'll let Dr. Walsh speak up. I think he's on.
Well, I think one area that can really help is in the rural setting. So I'm a rural general surgeon, and sometimes you can come across things, and if you're able to confer with a colleague to get you through, maybe it's that case, maybe it's a remote area that you can't transport easily. I've in the past, I've done it by telephone, where I called up my former teachers and arranged things for trauma cases, for vascular cases. But I can see this being very helpful in the rural setting, because there's a lot we can do in the rural setting, but sometimes we come across something different that we need help with, and need direction. It may be a matter of saying, stop there, drain, transport, can't transport, here's plan B. I think would be an invaluable way to do it. The other thing, just to put something out there, it can be helpful if people are spending a long time in space. David,
tell us about space.
So we're
going to go from rural surgery to outer space.
So you're not going to have all the specialties on that space station or on that moon base or on Mars. But if I can call up Rohan, and I'm on Mars, I'm the surgeon on Mars, he can probably help me get through some tough things that I might come across.
I don't doubt it. Not a bit.
I like that, rural surgeon on Mars. That's amazing.
Yeah. Well, it doesn't get much more rural than that.
Rural surgeon on Mars. We got it. Yeah, that's right.
No, I think this is really great. So I just wanted to ask the group about an ethical issue here. So I have been called by a previous, not one of my trainees, but somebody that I got to know, and I'm super proud of this because they called me from the operating room, asking for me FaceTime for advice on how to place an abrasion probe in the operating room. And I kind of wanted to ask the group, and maybe it'd be good to get some opinions from Dr. Chow or Dr. Benzie. What sort of legal ramifications does that have for me? Dr. Benzie?
Sure. I mean, I think it's someone you didn't train, right? You don't take that onus of responsibility or ownership from a legal, ethical, educational standpoint, but obviously you take that ethic of ownership of that patient now just as a human, right? And, for a colleague, I think that's very important. I think that really ties into this topic a lot too, and really the difference between telementoring and telesurgery, right? Where you as a surgeon operating that field are learning from the advice of others, but that person is not directly controlling your hands necessarily. They're just kind of illustrating the point. But ethically, does that person you've never trained document your name in their operative report, right? Is what it kind of comes down to too. So
Yeah.
do you get
And
named if something were to happen, right? And I think
right.
that is really
Or if one of the ORNSs were to say, if they were subpoenaed, oh, he had this person on the phone. This is really an interesting thing, because Dr. Welsh, I always think about our conversations. And so whenever I'm called from somewhere else with some disaster that, people are trying to send me, and I'm always saying yes, because I always think about Dr. Benzi's face at the other end, or any of my trainees, and obviously saying yes. I actually try to say, I usually say, please document in the chart that you spoke to me and this was my advice, because it makes people feel so much better about what they're doing. Most of the time, they're doing exactly the right thing. But just having that and telling the patient that just really helps. But I think you're absolutely right, Dr. Benzi. It opens me up completely, because medical legally that is an issue. But it was a really interesting deal. This also comes up with bile duct injuries. So, I will often get called from the operating room, which I'm thrilled to be called, because I'd rather be called from the operating room than 2 weeks down the line with a bile leak saying, does this cholangiogram look okay? And usually you're filling intrahepatics and nothing extrahepatic, or you're filling just extrahepatic and nothing intrahepatic. And I'm like, stop, leave the gallbladder in, put a drain, send them. We can just do an open chole and that'll be it. That'll be great. But if it's a bile duct injury, this is going to be the best thing for you, because it'll be recognized, treated. Nobody can blame you for this because you did everything right. So I just wanted to bring that up, because I think it really brings up some interesting ethical points with regard to telementoring.
Well, I would go the opposite and say, I think you're ethically responsible is to answer the question and help your colleague, right? So if they got a call for someone in distress, you'd help them just like you'd help someone who you walk down the street, and you should be protected for that. If it's a business where you have a more structured relationship, you probably do have liability. And that's why many people, when we proctor people doing sleeves or gastric bypass, they usually are our fellows or people we know who we trust will do what we ask them to do, and not just take our, have us there and do something else. But we all want to be able to help out when someone needs to have help, and not worry about who's looking over our shoulders.
But Rohan, that case that you had alluded to, of someone calling you from the OR for advice on an ablation probe, I'm curious as to what the beginning of that thought process was on the other end of that line, that individual. Were they planning on placing an ablation probe ahead of time? Was this an intraoperative decision? What was their plan going into it? Did they know what they were doing in the first place? Because what you don't want to have happen is to say, oh, we have this huge telemedicine, teleproctoring resource available for surgeon, XYZ. Does that then give a license for surgeon XYZ to start practicing out of their scope and use, oh, I can always easily phone a friend for a problem that I may or may not have?
Yeah, I think you bring up a really good point, Dr. Jula, and I think the issue is, I want to be frank. I mean, it was an interesting situation, right? Because if you're going to the operating room with a liver case, you probably should be able to place an ablation probe. But I think always help, right? Always help. So that's kind of my dictum. And it was an honor to be called by somebody who needed help. So I was happy to be called, but I do think you bring up the ethical dilemma and also the question of appropriate education. in this arena, this is where I think we need to be very cautious with new technology, and Dr. Jones is one of the pioneers in this area. But, as we bring on robotic cases, especially in the HPV arena, I mean, we can literally cause some serious issues, when you're operating around those major structures. So I have a really, really, really strong sense of what needs to go into this outside of, I think you need to be able to rescue. And what does rescue mean? Can you rescue from 200 feet away, or do you need to be able to rescue from 10 feet away? In many of my cases, 10 feet can be too far.
What's the difference between a preceptor and a proctor?
Aren't they the same thing? Is it more like a distinction without a difference?
Dr. Ross, did you come back? No. Juan, you haven't said anything recently. What do you think? Michael, I'm calling on you next, I guess.
We also have a fellow at the Methodist Richardson site who can jump in, hopefully, Dr. Mallow.
Or how about you, Dr. Jacob? I know you are very interested in rural surgery. So coming up next year, if you have situations like this, how will you use everything that you've learned through this talk and through your own experiences? Would you need a preceptor, or would you like a proctor when you first started your cases at your new hospital?
So I guess in the terms, I think of a proctor as like an exam proctor. So someone who's monitoring, but not necessarily involved in your education and how you carry out a case. But a preceptor, I think of someone who, like in medical school when you do preceptorships, but the idea of having an actual physician who is intimately giving you advice and monitoring not only monitoring, but actually educating you and teaching you, and has a more of a commitment to your growth and personal development. So I would think of preceptor as being someone who I would want to engage with in my practice.
And oftentimes, Dr. Jacob, we think of someone who can actually jump in with their hands and move your hands around. Now, if you're doing this remotely, are you a little more nervous?
If I'm honest, yeah, I would be a bit more nervous. But I think almost of the surgical telementoring platform, not just for elective cases, but kind of what I was talking of, like it's the middle of the night or there's a bad snowstorm and you have a ruptured AAA. Yes, you can call a vascular surgeon over the phone and talk with them through about your planned steps. And I mean, if I were encountering the snowstorm ruptured AAA, certainly I'd be nervous in the moment. But how great would it be, at least if I could press a button and have a vascular surgeon watching me as I am trying to repair this ruptured AAA in the middle of the snowstorm.
Cool.
I had a question for Dr. Jacobs. I'm Juan. I'm one of the fellows at Penn Health in Princeton Medical Center. So it was about I guess going back to the medical legal conversation, but specifically about the HoloLens, right? That's what it's called.
Yep.
So is there like currently a standard of regarding the liability of that surgeon that's providing the feedback, or I guess in the few cases where it's been actually being used in surgery?
So the specific instance that I talked about with the Ugandan surgeon, let's start with that case, I suppose. So yes, my understanding is they have a whole disclaimer and liability process for that, because it's a Mount Sinai established hospital essentially in Uganda. And so the faculty of Mount Sinai are also the faculty at this Ugandan hospital. And granted, they're 7,000 miles away, but it is sort of built into the structure of that hospital specifically. Now, if you're asking me, does HoloLens itself come with a surgical disclaimer? I would say probably not, but I actually don't know the specifics of that.
No, you answered the question. It was more about like the two physicians who are working together in a specific surgery. you know, it was more of an open-ended question of how do you deal with the liability issue, and also, you know, sort of thinking on that surgeon who's giving the advice from far away. Would you feel comfortable sort of putting your name down fully to be open to liability when you may not be able, I don't know if may not be able to even like see as well as the person who's there, if you get in a situation where being there is paramount, you know, being present is paramount, then how do you I don't know, deal, I guess, with the liability?
So Dr.
Yeah,
Jacob, do you think this great informed consent is going to prevent you from a lawsuit?
absolutely not. No.
So you got to be prepared to deal with that. I think if you're going to be teleproctoring, right? You got to, like anything else, set your you know, not just a good informed consent with the patient, but, you know, agreements with the team and good documentation and hopefully good advice.
Yeah, I mean, like I was saying, in emergency situations, kind of the austere environment, you know, when I was a medical student, when I was a surgical resident, I would often get consults from outside hospitals for trauma or for general surgery consults. And sometimes I didn't have the imaging over on the computer, and I would just have to ask them to rattle off all those details. If I felt comfortable saying, yeah, you can discharge the patient, I would say so, and have them come up in our clinic tomorrow. Or a lot of times I would say, you know, it's difficult for me to say over the phone, but based on what you're telling me, I would counsel you to transfer them over to us. And sometimes they did, sometimes they didn't, you know, it's a conversation with the patient too. But I treat it similarly to that, where you know, I was taking call. And so my role was as a consultant in that role. Now, if it's Dr. J. Raj's example, where it's a trainee who's calling him, not necessarily taking call, you know, I think I would probably follow suit as him and ask them to put my name in the chart, because I mean, it's just being open and honest as to what occurred. I have nothing to hide. A trainee called me asking for help, and I tried to provide it to the best of my ability. I could get named in the lawsuit, but at the end of the day, I think you know, I was trying to provide mentorship and advice to someone who needed it. So,
Dr. Chow and Dr. Lowe, you've been quiet. Anything to add?
Well, I just add that I think new laws need to be developed, right? Because if you look at like harassment laws and things like that, none of that really applies for things on the internet, right? No one could foresee people committing suicide because they've been harassed in the internet. So I believe that as this grows, it's new laws need to develop to protect the individuals. Now, if you look at the good way of doing it is that you look at the military. The military has their own laws. When people commit a crime or commit any type of problem or issue in the military, that's handled within the military. They don't bring it to a national court or anything else outside. And I see this technology probably would be best in the military because they have their own separate laws, right? So I think new laws really need to develop with this, and we should kind of look at the military and how they kind of use their laws in order to prevent people from trying to do good.
Well, I don't think the trial lawyers are going to let the docs write our own laws anytime soon, but we definitely need legislation to look at guidelines, rules, and policies.
Yeah.
Dr. Linga Manelli, I'm sorry if I pronounced that wrong, but we'd love to hear from you. We don't hear you. Gautam, are you there? You see the ceiling? Maybe not. Well, we can take two more questions. Anybody?
I guess wanted to ask another
Juan, go ahead.
question. Yeah, just from your perspective, your guys' perspective, do you feel, because I feel like that the US is sort of known to be a litigious place. So I can see where that example where you're helping the surgeon in another country could work, because I feel like other countries are just less litigious than the US. do you think that this could be something that could truly be applied in the US, to do maybe not routine surgery, but, surgeries in different states or different cities? Or do you think it's going to be more of an issue because of the medical legal aspect here?
Why don't we go around quickly and see what people think? Dr. Jacob?
So we have, teleconsult services now for, say, like dermatology, we have teleradiologists now as well. I think once we have a fully developed telementoring framework, I don't see why we couldn't have telesurgery to a certain extent. Now, it might start with, doing a remote consult, you being able to remotely get information about the patient. And based on what you're finding, you might say, oh yeah, I need to come in, or I need to call the local surgeon who might be 50 miles away and they need to start driving, So I think it could be integrated in the future in that way.
Dr. Welsh, you want the ACS to work a little harder for their dues?
Absolutely. There's an ethics group. Let's put them to work. I think
Annie, what do you think? Are we too litigious?
So I think that's what we're getting at is kind of like a Good Samaritan law that we need to start thinking about. Like if this is something that we're truly going to do, right? We as proctors, preceptors, or telementors, there is a humanistic quality, like you mentioned, Dr. Jones. Like we all want to help our colleagues. We all want to do well. But at the same time, what does that come down to? Our involvement in the decision-making process other than suggestions. But at the same time, I have a colleague now that retired from critical care medicine at bedside and is now doing telecritical care medicine. And how that works is that they have a PA that puts in lines, while that critical care physician is basically how you described your OR setup. So I think there has to be a basic level of skills for whoever that person is in the room. And I think that has to be part of the, consent-making capacity of the patient as well, to know who is there in the bailout or worst case scenario too.
I mean, we can all think of amazing surgeons that right as they retire, who you'd love to just have at your fingertips, right? Dr. Jayaraja, last words?
No, this is really stimulating, actually. Thank you, Dr. Jacob, for choosing a really, really unusual, sort of topic. I think that Dr. Ruar really hit the nail on the head, which is that unfortunately so much of this is just so blinded by the fact that we live in a very litigious environment. And it's really a shame because, as Dr. Welsh says, we really need to help our surgeons out in the community and kind of walk them through things. I've always said, like Dr. Benzie said, I'd rather stop practicing because I tried to do something good than not try to help somebody. And so if they're going to throw me in jail for that, great, that's fine. But I think it would be nice to be protected by a remote Good Samaritan law. So thank you for bringing that up, Dr. Rua, and great topic, Dr. Jacob.
Before we started, Dr. Benzie was very clear on my instructions. She wanted me to be interactive, but be on time. So with 1 minute to spare, I'd like to thank all of you for participating. And Dr. Jacob, great job for getting us stimulated and on topic. We covered a lot. We went back 30 years and we went to the future and we even went to the moon. So not too many groups can say that. So I'd like to thank all of you and have a wonderful holiday.
And
can you get a picture?
Add, Dr. Jones, we're all here to help all of you that are trainees. Seriously, we're just a phone call away. Okay.
Thank you.
Thank you. Thank you
Bye,
so much,
everybody.
everyone. Thank you, Dr.
Happy
Wait a second. We're going
holidays.
to take a picture for Twitter. Hold on 1 second.